Now let's discuss about the second point we have to learn in absorption is route of drug administration. So a drug can be given by two routes. The first route we call it as local route and second route is systemic route. Okay. So in local route, the drugs act locally and the drug is not absorbed. A drug is not absorbed into systemic veins. So the drug will have local action where it is given. While in systemic route, the drug gets absorbed into systemic veins. That is why it is known as systemic route. Now, local route is further divided into three types. So, the first route is topical. Topical means you are applying a drug on some surface. Now, this surface could be a skin surface, like you are applying a drug on a skin, or on a mucous membrane, let's say buccal mucosa, rectal mucosa, vaginal mucosa, or on mucous membrane. So the drug will act locally there. Second is into some cavity, and that cavity is a closed cavity. Into some closed cavity. Can you think about certain closed cavity in our body? Like synovial joints. So we can directly inject a drug into synovial joint. Let's say intra-articular injection into a synovial joint. Let's say the patient is having joint inflammation, arthritis. To control inflammation, we give corticosteroid. Like in osteoarthritis, rheumatoid arthritis, so we can give intra-articular injection of corticosteroids. So it will act locally here only. Similarly, any other cavity we remember? Yes. Intravesical. Intravesical means we are giving a drug into the bladder. Let's say the patient is having stage 1 cancer, very superficial cancer, which has not invaded into any other organ. To treat that cancer, can we give anti-cancer drug directly into the bladder? So the side effect of anti-cancer drug will not come any other. So intravesical injection is given in bladder cancer and we give an anti-cancer drug like mitomycin. There is a vaccine which is given for the treatment of cancer. You must have heard about this vaccine, a vaccine for TB, that is BCG vaccine. So these two drugs are given for superficial, which is initial stages of bladder cancer. Now let's talk about certain other route like intrathecal. Intrathecal means we are giving a drug into CSF. Let's say the patient is having brain cancer. Can we give intrathecal injection of anti-cancer drug like methotrexate, which we have discussed in cancer? Now, this is a very important route, intravitreal. Can you think about which cavity I am talking about? We are giving a drug into vitreous humor. So, vitreous humor is produced once in a lifetime. And if we inject a drug into vitreous humor, it will come in direct contact with the retina. And let's say in retina, there is some infection. So let's talk about a drug, let's say ganciclovir. Where word is coming? It is given intravitreal for treatment of CMV retinitis. CMV stands for which virus? Cytomegalovirus, and similarly there are many other enclosed cavity which we can think of. Now another local route is, sometimes we get confused, but it is a local route, that is intramuscular. arterial injection. Now remember, giving a drug into an artery is a local route. The reason is very simple. Let's say this is a limb of a person, hand of a person, and let's say if I will give a drug into artery, intra-artery, can you tell me the drug will move towards the limb? If I am giving a drug here, it will move towards the limb or it will move towards the heart. Artery takes the blood towards an organ. So let's say I have given an intra-arterial injection, it will move towards the organ. And let me apply a pressure above the arm. Let me apply a pressure so that a drug cannot move back. In intra-arterial injection, the drug will have local action in the hand and this wrist area. So intra-arterial is a local route. And we give intra-arterial injection in cases of limb cancer so that we can avoid the side effect of anti-cancer drug in the whole body. So in limb cancer, we give anti-cancer drug by intra-arterial route. Okay. Now let's talk about systemic route. So in systemic route, the drug comes into the veins, it reaches to the heart, and through heart, it will get distributed into the whole body. Now, in systemic route, it is further divided into two types. First is enteral route. Enteral means through GIT. Enteral means through GIT, a drug will come into the blood. And the first route in enteral we will write as oral route. So in oral, the drug gets absorbed from stomach and more from small intestine. Apart from oral, we have sublingual because keeping a drug below the tongue, and this is still the part of GIT, and rectal route. So sublingual, oral and rectal are through GIT, they are enteral route. Now apart from GIT, all other routes we call them as parenteral routes. Parenteral means apart from GIT, all other routes are parenteral routes. Now these parenteral routes are further divided into two types. One is injectable route, second is non-injectable route. Fine. So we have various types of injection like IV. Can you tell me IV? IV stands for intravenous. Intravenous is a systemic route, intra-arterial is a local route. IM, intramuscular. IO, IO means into a bone, intraosseous. ID, intradermal. SC, subcutaneous. And we have non-injectable route, transdermal. Transdermal means a drug given on skin and getting absorbed into the blood. Trans means through skin. Don't confuse between transdermal and topical route. In topical route, the drug will remain on the skin. In transdermal, it will get absorbed through the skin and come into the blood. Transdermal is a systemic route. And last route is inhalational. So two routes which are non-injectable are transdermal and inhalational. So we are going to discuss all systemic routes in great detail. So let's start first with enteral route, that is oral route. And this is a very important concept. Many questions comes out here. So in oral route, a drug gets absorbed from through which part of GIT? Through small intestine and stomach. And why all drugs are absorbed from small intestine? Because small intestine has a greater surface area. Now there are certain advantages of oral route. Now oral route always is the safest route. The reason is we have liver, intestine, and enzymes, and if a harmful molecule gets absorbed, these enzymes and liver and molecules or enzymes, many transporters, enzymes, and molecules are there, they remove that toxin or harmful product. Oral route is the cheapest route because to make a tablet, it is cheapest. Injections are costly. It is also the most preferred route by the patient because patient don't want to take injections. Injections are painful. But what is a disadvantage? Can you give a drug orally in unconscious patient? No. Can you use this route in emergency? No. The point is, can you predict how much amount of drug will enter into the blood? Can you predict bioavailability of a drug? So unpredictable bioavailability. So these are the certain drawbacks of enteral route, but these are not asked in MCQ. What is asked in MCQ? Let's understand this part. Now, in oral route, the drug is absorbed from small intestine and stomach. Now, second point is, in oral route, the drug undergoes, first pass metabolism. Now, this is the most important point. The drug undergoes first pass metabolism in GIT. Now, what does it mean? Let's understand. Let's say you have taken a drug orally. So, when you have taken a drug orally, a drug gets absorbed from stomach and small intestine. Now, you remember anatomy. All the blood of stomach and small intestine, it first drains into a vein known as portal vein. And all this portal vein blood, it drains into the liver. Fine. And from liver, we know inferior vena cava arises. And this inferior vena cava finally drains into the heart. And the amount of drug which is finally reaching to the heart will be available for us because this heart will pump the drug to each and every organ where it will act. So the final amount of the drug which reaches to the heart is known as BA, that is bioavailability. Now in this whole pathway, we can see liver is coming in between. And liver has certain enzymes. Liver is the chemical factory of the body. And if liver identifies this drug, before this drug can reach to the heart, liver will degrade this drug. So don't you think this liver can degrade this drug? This is known as first pass metabolism, which mainly occurs in liver. Agreed? So is there any other area where first pass metabolism can occur? That is, the walls of stomach and small intestine also contain certain enzymes which can degrade a drug. So first pass metabolism can occur in GIT mainly in liver. So just write the word liver mainly. Now this first pass metabolism, it is also known as first pass metabolism is also known as first pass effect. Another name of first pass metabolism is pre-systemic metabolism. Because when the drug reaches to the heart, we finally say the drug has reached into systemic circulation. So the drug is getting degraded beforehand. We call it as pre-systemic metabolism. Now let me explain you in simple terms. That if I have given, let's say, 100 milligram of the drug, this drug went to the liver and finally you saw only 40 milligram of the drug is coming out of the liver into inferior vena cava. Can we say only 40 milligram will reach to the heart? And in between there is a liver. So can we say liver has degraded 60 milligram of the drug? So can we say now less amount of drug is available? That is why first pass metabolism of a drug reduces bioavailability of a drug. This is a very commonly asked question. Now less drug will be available in our body. So one question comes, sir, how we can calculate this first pass metabolism of liver? Very simple and easy to remember. So first question is how to calculate the first pass metabolism of liver. So let me make that diagram again for you. So this was stomach, this was portal vein, this was liver, this was inferior vena cava, and finally heart. Now, let's say I have given 100 milligram of the drug and I am getting only 40 milligram of the drug outside. Can we say liver has degraded 60 milligram of the drug? So let's see how do we calculate. Now beta, I am using a word first pass metabolism. I am using the word metabolism. So can you recall which pharmacokinetic parameter shall I use? Is it bioavailability? No. Is it volume of distribution? No. Is it clearance? Yes. Whenever we call and discuss metabolism, we use a word clearance. So first pass metabolism of liver, it is also known as hepatic clearance because we are now discussing metabolism. And hepatic clearance, how it can be calculated? Let's say the drug which is in portal vein is Ca and the drug which is coming into inferior vena cava as Cv. So can you tell me how much drug liver has degraded? Sir, liver has degraded Ca minus Cv, that is 100 minus 40. So when we give 100 milligram of drug, around minus 40, 60 milligram of the drug will be removed. Now let's make it as a ratio divided by Ca. Because if I will divide it by Ca, it will become 60% or 0.6. That means whenever I will give a drug, 60% of the drug will be degraded. So 100 milligram if I will give, 60 milligram degrades. 200 milligram if I will give, multiply 200 minus 80 divided by 200 will be around 120. Again 60% will be degraded. So this becomes a ratio. So this ratio we call it as extraction ratio. So it will tell us in one go how much liver will degrade a drug. So it degrades 60% of the drug. Now, when I give a drug at one moment, 60% of the drug is degraded. But think logically, when we take an oral drug, the drug is getting continuously supplied to the liver. है ना? Whole of the drug will not be degraded in one go. The drug will be continuously degraded with time. And who is bringing the drug to the liver? The portal vein blood is continuously bringing a drug to the liver. So in one go, the drug which is degraded is extraction ratio. Let's multiply it by hepatic blood flow. So if we multiply it by hepatic blood flow, that means this blood is now continuously delivering a drug. So this will tell us how much amount of drug will be degraded in first pass metabolism in long duration of time. So it tells us about hepatic blood flow. So in simple word, hepatic clearance is extraction ratio into hepatic blood flow. And I want to tell you a secret. If you want to calculate clearance of any organ, whether it is kidney or any other organ, this is how we calculate. We multiply it by extraction ratio into blood flow to that organ. Okay. Now, the second question which comes is, if a drug has a very high first pass metabolism in liver, would you like to give that drug orally to your patient? The answer is no. So, if a drug has a very high first pass metabolism, either these drugs are not given orally. But if I will ask you, sir, there is some compulsion, we have to give this drug orally. So, will you give them in normal dose or a very high dose? So, if a drug is having high first pass metabolism, either they are not given orally or they are given in very high oral dose, more than required, so that some amount of drug finally reaches to the heart. So, which drugs are not given orally? Because it is degraded by liver, and this question is very commonly asked, the answer is lignocaine. So, lignocaine is not given orally. Why? Just recall, lignocaine liver degrades. Another drug is fentanyl. Fentanyl is an opioid. Question which was asked recently in all exams. Fentanyl is not given by which route? Oral route. And lastly, we will write natural steroids. Can you think about certain steroidal hormones produced in our body? Yes, like estrogen, progesterone, testosterone, glucocorticoid. Heard about glucocorticoid like hydrocortisone? And heard about natural mineralocorticoid produced in our body? Aldosterone. So how we can remember steron, they are steroidal hormones. When taken orally, liver degrades them. Now, have you thought about sometimes about a drug, oral contraceptive pills? Beta, in oral contraceptive pills, that is oral contraceptive pills, can you tell me why we don't use natural estrogen? Why we don't use natural estrogen in oral contraceptive pills? Because natural estrogen has a very high first pass metabolism in liver and it is not absorbed. That is why in OCP, we rather give, in oral contraceptive pills, we give a synthetic estrogen known as ethinyl estradiol, which we have discussed in endocrine chapter. Now the drugs which are given in high oral dose, we can remember PM, VP, SYN. So P for propranolol, the beta blocker. It is given in high oral dose. Morphine, one calcium channel blocker, verapamil. Then another opioid, younger brother of morphine, pethidine. Salbutamol, which is given for asthma, and nitrates, which are given for angina. Now, heard about salbutamol. Salbutamol is given in asthma. It is given by spray, nasal spray, inhalational route. Do we use salbutamol orally? Yes. In small children, we give syrups of salbutamol. Hence, salbutamol is not just an oral drug. It is also given by syrups or tablets. Now, sometimes it is asked, which drugs are asked? Propranolol is a commonly asked question. So, try to remember propranolol at least, and nitrates and salbutamol. So, if a drug has a high first pass metabolism, you cannot give a drug orally. So, the question comes, how we can avoid this unnecessarily first pass metabolism of liver. Liver is unnecessarily degrading a drug. Making a drug is costly. So the answer is how we can avoid or bypass this first pass metabolism of liver. The answer is by giving a drug, by giving a drug by all other systemic routes except oral. So in oral route only, the drug undergoes first pass metabolism in liver. Rest all other systemic route, if we can remember, that is sublingual, rectal, and all parenteral routes, the drug does not go to the liver. The drug directly reaches to the heart because all other routes like sublingual, rectal, and parenteral route, the drug does not come into portal vein. Only in oral route through stomach and small intestine, the drug first enter into portal vein and portal vein drains into liver. So rest all other route, they bypass first pass metabolism of liver. Agreed? So the only route which has FPM is oral. So keeping this thing in mind, let's talk about the second enteral route, that is sublingual. With sublingual, you can also write a similar route, buccal route. So what happens in sublingual route? We place a drug below the tongue. Sublingual means below tongue. So we have placed a drug. A drug gets absorbed through sublingual veins directly into superior vena cava. Sublingual veins directly drain into superior vena cava. They are not draining into portal vein, and through superior vena cava, a drug directly reaches to the heart. So, do you think liver is coming in between? No, liver is not coming in between. It bypassed the first pass metabolism of liver. The classical example is sublingual nitrates. So two nitrates we will write for a moment, that is GTN, glyceryl trinitrate, and ISDN, that is some isosorbide dinitrate, which we have discussed in angina. Don't you think sublingual route will be a very fast route? Yes. So you will give them in acute attack of angina or prevention of angina. It's a very fast route and it is the only drug we have for acute attack of angina. Rest all other angina drugs are for prevention of angina, long-term prevention of angina. Next route is rectal route. So when you give a drug into rectum, suppose this is a rectum. Now this drug gets absorbed into a vein. We call it as external hemorrhoidal vein. Now external hemorrhoidal vein, it is a tributary of inferior vena cava which drains into the heart. So it does not drain into portal vein. It's a direct tributary of inferior vena cava. So this external hemorrhoidal vein bypass the first pass metabolism of liver. But remember, you will find a question, and if you recall anatomy, there is another vein which is even more deeper into rectum. That another vein is internal hemorrhoidal vein. Internal hemorrhoidal vein. Remember, internal hemorrhoidal vein is a tributary of portal vein. It first drains into liver. From liver, it will come to the heart. So, in which vein drug bypasses liver? Is it external or internal hemorrhoidal vein? The answer is external hemorrhoidal vein. And the classical example is rectal diazepam. So this rectal route is very much commonly employed in small children. Because in emergency it is very difficult to find veins. So IV route which is given in emergency is difficult to do. So we give rectal route in small children, and this rectal diazepam, it is the drug of choice for febrile seizures. Febrile means high grade fever. When occur in small children, it can induce seizures. So the drug of choice is rectal diazepam. So rectal and sublingual route, they bypass liver. Now let's talk about parenteral routes. So in parenteral routes, first let's discuss about injectable route. And the first route is intravenous. Short form IV. So in intravenous route, beta, what we do, we give a drug into a peripheral vein, and that vein is directly going into the heart, and we inject the drug into a vein. Now beta, I want to ask you, let's say I have given 100 milligram of the drug. Can you tell me how much amount of the drug will come into the blood? Yes sir, 100 milligram. And how much will reach to the heart? 100 milligram. So can we say there is no cellular barrier in intravenous route? So in intravenous route, there is no cellular barrier. Whatever the drug we load in an injection, whole of this drug directly enters into the blood. So can you tell me in which route there is no absorption of a drug? Absorption means crossing a cellular barrier. So there is no absorption of a drug. Is IV route. Now can you tell me what will be the bioavailability of IV route? How much percentage of the drug is going to the heart? That is 100%. So IV route has 100% bioavailability. Why it has 100% bioavailability? Because there is no cellular barrier, and it is a very commonly asked question. Now another good point about IV route is, in IV route, dose titration of a drug is possible. We can do dose titration of a drug. Now beta, what do you mean by dose titration? Dose titration means that we can change the dose little bit according to the effect of a drug. That means we can modify the dose according to the effect of a drug. What does it mean? Let's say beta, I have started intravenous insulin. Let's say I have started intravenous insulin, and insulin is producing hypoglycemia. So I will reduce the dose. If insulin is producing hyperglycemia, I will increase the dose. So I will continuously change the dose to produce best effect. This is known as dose titration. And dose titration can be done by two routes. First is intravenous, and second is inhalational route. So you must have heard about during surgeries, either we give IV route and we put an endotracheal tube and give inhalational anesthesia gases like general anesthetics. How we can adjust the dose? We continuously give general anesthetic gases and we see the effect on the monitor. Respiratory rate, blood pressure. Let's say the respiratory rate is falling. That means anesthesia is producing lot of effect. So we will reduce the dose. Patient is getting conscious, waking up, we will increase the dose. So this is dose titration. So dose titration is possible in two routes, that is IV and intravenous. So this intravenous is the route of choice during emergencies, during surgeries, and it has predictable bioavailability. That means how much amount of drug we are giving is, we know how much it will reach to the heart. Now the second route is IO. IO stands for intraosseous. Intraosseous means we are giving a drug into a bone. So we are injecting a drug into a bone. Now, which is the most common bone where we give IO? The most common bone is tibia. The reason is very simple. Tibia is such a long bone, not covered by muscle, directly attached to the skin. So if there is some emergency, you can easily find tibia. Now, in which case we give intraosseous injection when intravenous route is not possible. Can we say when veins are collapsed? When veins are not opening, they are collapsed. Veins are collapsed when there is no blood pressure, when the blood pressure is too low, and vein becomes collapsed in low blood pressure, and that condition is known as shock. So in shock, venous access is difficult to find. So you directly give an injection in emergency into a bone. So in shock treatment, we give fluids and we give vasopressors like adrenaline, noradrenaline directly into the bone. Okay. Now, let's talk about three routes together. First is IM, second is SC, and third is ID. IM stands for intramuscular, subcutaneous, and intradermal injection. Okay. Now, first question which is asked is, what is the angle of needle when you are giving this three injection? So let me explain you. Suppose, sir, this is a skin and this is epidermis. And these are dermal papillas. Above them, the skin is highly keratinized. Lot of dead proteins are there. No blood supply. Now, below it, we have dermal blood vessels. So here we have dermis. Dermis means dermal blood vessels, which is dermis. Below it, we have lot of fat, which you call it as subcutaneous fat. And beneath it, we have muscles. Muscles also has very good blood supply. Muscles also have very good blood supply. So this is muscles. Now, beta, very simple. If you want to give drug directly into the muscle, so if we want to give a drug directly into the muscle, we must give injection directly into the muscle. Agree? If we want to give a drug into subcutaneous tissue, this is IM. We should give into subcutaneous fat. And if you want to give a drug directly into dermis, we should give an injection into dermis. It will get absorbed from intradermal blood vessel. Now, can you tell me what is the angle of needle in intramuscular route with respect to skin? So, angle of needle in intramuscular route is 90 degree. In subcutaneous, 45 degree. And in intradermal, very much parallel to skin, 10 to 15 degree. Okay, 90 degree, 45 degree, 10 to 15 degree. So let's talk about this diagram. You can easily see that in intramuscular, we give an injection directly like this. So suppose this is the skin, we give like this 90 degree, subcutaneous 45, and if it is intradermal, we give very much parallel to it. Okay. So let's talk about first intramuscular route. So in intramuscular route, we inject a drug into muscle. And muscle has lot of blood vessels and the drug gets absorbed into the blood. Now, intramuscular route, if we give a water soluble drug, the drug is rapidly absorbed. Okay. Now, what I have done with this water soluble drug, I have attached a big lipid moiety. I have attached a big lipid moiety. Can we say the drug has now become totally lipid soluble? Yes. Now this drug will get very slowly absorbed. Don't you think this lipid moiety will remain deposited in muscles for long duration of time? Lipid moiety don't want to come into watery media like blood. So we can convert a rapidly absorbed drug into a slowly absorbed drug. So can we say a short acting drug can become a long acting drug? So this long acting preparation of intramuscular injections, they are known as depot preparation. They are known as depot preparation. Depot means the drug will remain deposited for long duration of time and now it is slowly and slowly released. So we can make a drug long acting. Let me give you a beautiful example. Let's say there is an antipsychotic drug, haloperidol. Haloperidol is a very water soluble drug. When given intramuscularly, it has a very fast onset of action. What I have done, I have attached one lipid moiety with haloperidol. You don't have to remember the name of that lipid moiety, undecanoate. And this is an oily preparation. Oily means lipid preparation. And this lipid preparation, it becomes very long acting. And this type of preparation is known as intramuscular depot preparation of antipsychotic. So it is given once a month. So we need this drug because antipsychotic drug are given in psychotic patient. Psychotic patient don't believe they are suffering from a disease. They don't take a drug orally themselves. So we call them give an intramuscular depot preparation of antipsychotic which act for once a month. Discussed in antipsychotic chapter in more great detail. So remember, this is intramuscular depot preparation. Now, another problem with intramuscular injection is, let's understand, sir, when we give an injection into the muscles, let's say I have given an injection into the muscle and now I have removed the needle. And this is the fascia which is covering a muscle. And I'm giving an injection into the muscle and I'm puncturing this fascia. Now I have removed the needle. Now, don't you think this drug can again come back? And if this drug has some color, above muscle, I have told you we had subcutaneous fat. Don't you think this drug can lead to staining of subcutaneous fat? That means if this drug again comes out of a muscle, it can lead to staining of subcutaneous fat. So intramuscular injection of certain drugs like iron has a color, it can lead to staining of subcutaneous fat. Color of the fat will become brown or black. Cosmetically, patient will not like it. How to avoid the staining of subcutaneous fat in intramuscular route? We have a technique known as Z technique. So let's talk. It's a very commonly asked question. So what is the Z technique of giving intramuscular injection? Z means beta zigzag. When I will give the injection, first I will pull the skin downwards. Now, when I will pull the skin downwards, what will happen? The fascia of the beside muscle, neighboring muscle will cover it. Now I will give the injection. Agreed? The drug is deposited inside the muscle. Now, after giving injection, now I will push back the skin backward. Now, when I will push the skin backward, the punctured fascia will go back and a normal fascia will cover the muscles. Because of this reason, the drug will not able to come back into subcutaneous tissue. So pull the skin down, give an injection, then push the skin back. So pulling the skin, pushing the skin back, this technique is known as zigzag technique, known as Z technique. So Z technique is given to avoid it is given to avoid staining of subcutaneous fat. So this technique is zigzag technique, staining of subcutaneous fat. And which drugs are given by Z technique? Commonly asked question. First is iron injection. So you can write iron dextran injection. Second is antipsychotic drugs. Antipsychotic drugs are given by Z technique and it is given to avoid staining of subcutaneous fat. Now let me discuss about the other route. Then we have subcutaneous route. So here the drug is given by injection or the drug is delivered through a vacuum which is known as dermojet. So we have small hollow vacuum needles through which a drug can be injected. And when we give a drug subcutaneously, it enters into subcutaneous fat and then it gets absorbed into dermal blood vessel above it. Dermal blood vessel. Okay. Classical example we all know is injections of insulin, which a patient can take on long-term basis for the treatment of diabetes. Injections of low molecular weight heparin. Then we have intradermal. So intradermal injection, it is given for allergenic testing. It is also used in certain vaccines like BCG vaccine. So MCQ don't come on intradermal routinely. Now let's talk about, can you tell me, there is a contraceptive implant which is implanted in subcutaneous tissue. So this implant, which is having 6 rods of one contraceptive known as levonorgestrel, and this contraceptive is known as norplant. So norplant is a contraceptive which is implanted into subcutaneous fat and it slowly releases the drug. It is effective for 5 years, which we have discussed. Now let's talk about the non-injectable parenteral route, that is transdermal route. So trans beta means through skin the drug will get absorbed. So most of the time we apply a patch over the skin. So what happens, suppose this is the skin, we apply a patch. So drug gets absorbed through simple or passive diffusion and it gets absorbed continuously into dermal blood vessels. Okay. Now, first point with transdermal route is, sir, how you will decide the dose of a drug? I will give you 2 options. Think logically and tell me. First thing I can do is increase the area of patch, increase the thickness of patch. Or second thing what I can do is increase the area of patch. Can you tell me which method, increasing thickness or increasing the area, which method can deliver more amount of drug? Yes, it is area of the patch. Increase or decrease the area. So dose of the drug depends upon area of patch. That is why when you see any transdermal patch, their dose is written as centimeter per square, millimeter per square. Now, what is the advantage of transdermal patch? Let's say you are sleeping and you have applied a patch. Don't you think the drug, even at that time, will be continuously delivered? So, transdermal patch delivers constant amount of drug round the clock. So even when you are not doing anything, not eating a drug, if you have applied a patch, it will continuously deliver the drug. So transdermal patch, that is why they are given for acute emergency condition or they are given for long-term disease. Yes, they are given for chronic or long-term disease. Okay, and the great advantage is that they provide non-fluctuating or constant constant blood level of a drug. So the drug will remain constant in blood because it is continuously delivered into the blood. So let's talk about which site we should apply a patch. So the site of maximum absorption in a transdermal patch. So in a transdermal patch, site of maximum absorption is posterior auricular area. That is on mastoid process behind pinna. Second, scrotum. Third, face and neck. You can also apply on arms also, abdomen also, but I am talking about site of maximum absorption. So what is the site of least absorption? Sir, site of least absorption is where the skin is very thick, hyperkeratinized. Can you tell me which area of the body the skin is very thick? Yes, palms and soles. So sometimes the question comes, in which area we never apply a transdermal patch? Palms and soles. So let's see the examples of certain drugs which are given by transdermal patch and try to answer before I write their indication. Can you tell me where do we give nicotine transdermal patch? They will deliver nicotine continuously so that the person will not have craving for cigarette. So it is given for smoking cessation. Okay, we have nitrate patch. But I told you nitrate was given for angina. Sublingual route was a very fast acting route given for acute attack of angina. Nitrate patch will be a long term or long acting route. It is given for long term treatment of angina, which you call it as chronic angina. Now, very important, many times asked question, is a drug known as hyoscine. Hyoscine, it is also known as scopolamine. And another drug is diphenhydramine. Anticholinergic drug hyoscine, antihistaminic drug diphenhydramine. These two drugs are given for motion sickness. When you sit in a car or a bus and you feel nausea and vomiting, that is motion sickness. Then, which is the only drug approved for depression as a transdermal patch? That is salicylic. Now, don't you think if a patient of Alzheimer disease comes to you who has habit of forgetfulness, don't you think giving a transdermal patch of rivastigmine will be very beneficial? So rivastigmine patch is given for Alzheimer's disease. Many times asked question. Similarly, for Parkinson's disease, we have rotigotin patch. Now, clonidine is also available as a transdermal patch for the long-term treatment of hypertension. And we can give natural estrogen. Remember, natural estrogen I told you cannot be given orally. Natural progesterone cannot be given orally because they undergo first pass metabolism in liver. In transdermal route or any other systemic route, the drug does not have first pass metabolism in liver. So natural estrogen and progesterone are given by transdermal patch in postmenopausal female as HRT, hormone replacement therapy. Okay. So this list is very important. So sometimes a picture might be asked. So you can see nicotine patch. Can you tell me the indication? Yes, smoking cessation. Can you tell me scopoderm, which is written as scopolamine? Scopolamine patch. And it is applied behind pinna in posterior auricular area, site of maximum absorption. Can you tell me scopolamine patch given for motion sickness? And recently, rivastigmine patch was asked. It is given for Alzheimer's. Okay. Now let's talk about the last route, that is inhalational route. Now inhalational route is both local as well as systemic. That depends upon for which disease you are using. Let's say the patient is having asthma. In asthma, bronchoconstriction occurs. So we give bronchodilator. And don't you think bronchodilator will have local action in bronchus? Absolutely fine. So they will have local action. Now, if the drug molecule is very small and drug reaches to the alveoli, it gets absorbed into the blood also. So which drug we want inhalationally to go into the blood? That is anesthetic gases. Anesthesia gases, they get absorbed into the blood and hence they have systemic route because from blood they enter into the brain. So it can be both local as well as systemic. Now the question is, if we want the drug to remain in the bronchus, can we say the size of the drug molecule should be large? And if we want the drug to reach to the alveoli, its size should be small. So whether the drug will remain in the bronchus or it will reach to the alveoli, that depends upon the particle size of the drug. So to produce local action, a drug should have large particle size, and that particle size is 2 to 5 micron in diameter. And to reach into the smaller alveoli, the drug should have small particle size, that is less than 2 micron in diameter. So that depends upon where the drug is acting. So this is all about the absorption and the route of administration. Now let's talk about the last parameter, the thing which we have to discuss in absorption is to calculate bioavailability. So what is bioavailability? Let's write the definition. Bioavailability, it is the fraction of a drug that reaches systemic circulation. And with systemic circulation, we mean artery or vein? Yes, we mean veins. So what is the symbol of bioavailability? F. Why? It is a fraction. Now, beta, just imagine you have taken a drug orally. Do you think the drug reaches into the blood suddenly or it comes slowly and slowly with time? Yes, it comes with time. So the second point we should add is with the time. And which drug we are talking about? The drug which is degraded by the liver, or the drug which is not metabolized, not degraded by the liver? Yes, the drug which is spared. So the drug which reaches into the blood with time in unchanged form is bioavailability. So remember, with time in unchanged form. So if you have given 100 milligram of the drug, with time 40 milligram of the drug is reaching into the blood as such without getting degraded is bioavailability. So one question comes that how we can calculate this bioavailability. So let me make the things simpler. Let's say you have taken an oral drug, and now what happens, we will draw a diagram. The drug is coming slowly and slowly into the plasma. So let's see the plasma concentration of the drug. And drug is coming with time. Hence we make a graph known as concentration time graph. Okay, so let's call this graph as concentration time graph. Now let's say you have just given a drug at 0 time. Can we say the drug will not be in plasma? Now, after 5 minutes, you took a blood sample from plasma. You found this much amount of drug. After 10 minutes, you took plasma sample. This much amount of drug you found. So you keep on taking different plasma sample with time. And let's say this is the concentration in plasma you are finding with time. Now let's join the dots. So if we join the dots, this is the total amount of drug which is coming into the plasma with time. Agreed? So this is the total amount of drug which is coming into the plasma with time. Let's call it as AUC. So let's say I have given a drug orally. Okay? And AUC stands for area under curve. Okay? In unchanged form. Now I want to ask you, what is the bioavailability of intravenous route? Intravenous route has 100% bioavailability because there was no cellular barrier. So what about all rest of the routes? Oral, intramuscular, and intradermal, all other route, they will have less than 100% of bioavailability because some sort of cellular barrier was there. So because of this reason, this IV route, it is taken as standard, and we compare this IV route and we calculate the bioavailability of all other routes. Okay. Now, what is this? Let's understand in a simple way. Let's say you have taken a drug orally. So let's draw a diagram. And this drug is coming into the plasma with time. So let's make a graph known as plasma concentration with respect to time. Let's call this graph as concentration time graph. So let's say you have taken a drug orally. At 0 time, can we say drug will not be in the plasma? After 5 minutes, you have taken a plasma sample, blood sample, and you found this much amount of drug. After 10 minutes, you found this much amount of the drug. After 15 minutes, you found this much amount of drug. So you are keep on taking, you are repetitively taking different plasma sample at different time point. So this is the concentration we are finding with time. So let's join the dots. So if we join the dots, can we say this is the total amount of drug which is coming into the plasma with time? Let's call it as AUC. AUC stands for area under curve. So area under curve tells us about the total amount of drug coming into the plasma with time. Now, this AUC will have certain value. Agreed? Now give that same amount of drug by IV route. Give that same amount of drug, let's say 50 milligram oral, 50 milligram IV. So when I have given that same amount of drug IV, I will make a graph. So IV route I have given just here. Now I am taking the different time point blood sample. So this will be the shape of IV route and this will be the area under curve of IV route. Now think logically and tell me which route will have higher area under the curve. Yes, it is IV route because IV route has 100% bioavailability. Whole amount of drug will come into the blood. So AUC of IV route will always be higher. So how do we calculate bioavailability? Let's see. The formula is when we want to calculate bioavailability, it is area under curve of concentration time graph when you have given a drug orally or by any route which you want to calculate, and divide this area under curve oral by area under curve of concentration time graph when you have given that same drug IV. Can you tell me why IV is always taken as denominator? Because IV will have maximum bioavailability, which is equal to 100%. Oral will have a little bit lesser area under the curve. So if let's say the area under the curve of oral is 95, okay, and in IV it is 100, so the bioavailability will be 0.95 or 95%. So as compared to IV, only 95% of the drug comes into the blood. Agree? So first question is, what is the units of bioavailability? Bioavailability has no units. Why? Because numerator and denominator are same. And if they both are same, they will cancel out each other because it is a fraction. And fraction has no units. Fraction has same numerator and denominator. That is why the symbol of bioavailability is F. Now another question which comes is, sir, how we calculate this area under curve? If you see this area under curve, it does not have any shape, but we can make a shape. How? Let's divide this area into different parts. Now, let me take one segment of this area. Let's say I have taken this segment. Now, this segment has a particular shape. And if you remember, two sides are parallel, two sides are not parallel. This shape is a shape of trapezium. So it is a trapezium shape. And we know how to calculate the area of trapezium. Yes. And we can add each trapezium area with each other and we can calculate whole AUC. So area under curve, it is calculated by a rule known as trapezoidal rule. Only this point you have to remember. So we divide them into different trapezium. We add area of each trapezium. This is how we calculate AUC. And then we divide to calculate bioavailability. Now, let me make things a little bit more complicated. Let's say there is a drug A. Agree? And there is another drug B. Fine. And this is concentration time graph. Can we say this A is coming into the plasma And this is the maximum concentration of A in the plasma. Let's call this maximum concentration of A as Cmax. And this is the Cmax of B. This is the Cmax of B. Now this Cmax of A, it is coming into the blood at this time. This is Tmax of A and this is Tmax of B. Now, can you tell me among A and B, which drug is coming into the plasma faster, rapidly? Yes, the answer is A is coming rapidly into the blood, B is coming slowly into the blood. So rapid and slow, through which parameter you have diagnosed? Rapid and slow means time. So Tmax on this concentration time graph, it tells you about rate of absorption. It tells you about rate. Wherever the word rate comes, rate means time, which is equal to the speed of absorption. So if a drug has shorter Tmax, small Tmax, the drug gets absorbed rapidly. And if a drug has a higher Tmax, the drug comes into the blood slowly. What about Cmax? Cmax tells you about the maximum plasma concentration of a drug which can be achieved. And this total AUC, which was area under the curve tells you about the total extent of absorption. It tells you about total extent of absorption. That finally how much amount of the drug is coming into the plasma with time. Now this Tmax is a very commonly asked question. Rate means time. Tmax tells you about the rate of absorption. Now there is a technique in which we can convert this fast absorbing drug like A into slowly absorbing or long acting drugs. How we can convert these drugs? A fast absorbing or fast acting drug into long acting drug. This method of increasing the Tmax is a modified preparation of a drug known as sustained release preparation. Sustained release preparation, which are also known as controlled release preparation, their function is to increase the Tmax of a drug. That means delay the absorption of a drug, delay the rate of absorption. Now, how do we do that? Remember, we make a tablet and we most of the time cover the tablet with some inert polymer. And that inert polymer will lead to slow dissolution of a drug. The drug will now slowly dissolve. And if the drug will get slowly dissolved or slowly becomes free, it will get slowly absorbed. So in which drugs we make sustained release tablet? If a drug is having very fast absorption, given for a long term disease, let's say there is a drug known as nifedipine. Now nifedipine, it has a very fast absorption, fast or sudden absorption because its Tmax is very less. But it is given for the treatment of a long term disease known as hypertension. So you need a fast acting drug or a very slowly acting drug. We need a very slowly acting drug. Similarly, theophylline, which is used in long term treatment of chronic asthma. Again, it has a very fast or sudden absorption, and these are long term disease. So because of this reason, because of the nature of the disease, we make sustained release preparation of nifedipine and theophylline to increase their Tmax. So it will delay the rate of absorption. Now this is all about bioavailability. Let's talk about a similar term like bioavailability, that is bioequivalence. Now beta, if you see dictionary, what do you mean by equivalence? Equivalence means to compare two similar things and see how much they are equal to each other. So bioequivalence means when we compare bioavailability of two brands of a same drug. So two different brand of a same drug, they are also known as generic drugs. So when we want to compare the bioavailability of two brands of same drug, it is known as bioequivalence. Let me make the thing simple for you. Let's say you went to a chemist and you ask for crocin. Crocin contains paracetamol 500 milligram, which had certain bioavailability. Let's say the bioavailability is X unit. But the chemist said to you, sir, I don't have crocin. I have some another brand of paracetamol with 500 milligram. Let's say that brand is Dolo or Calpol. Okay. So you say to chemist, sir, no, don't worry. I will take another brand also because I need paracetamol. Any brand will work for you. Now, these two brands are made by different manufacturer. So don't you think another brand can have little bit higher bioavailability as compared to crocin? Let's say that brand is Dolo. Or Dolo can have little bit lesser bioavailability than crocin. Exactly same bioavailability is very difficult to achieve. So we say that if there is little bit variation in bioavailability, it is acceptable to us. How much variation is acceptable to us? If another brand is getting absorbed up to 125% more or up to 80% less, beyond this, this much variation is acceptable to us. That means 20%, 25% variation in two brands is acceptable to us. And if two drugs, they lie between this acceptable range, we call these two brands as bioequivalent to each other. They are almost equal to each other. So, what is the acceptable range of acceptable variation in bioavailability of two brands? The answer is 80 to 125%. If two brands lie between this range, we call these two brands as bioequivalent to each other. They are almost equal to each other, and we don't have any problem with the 25% variation. And because of this reason, we can interchange the brands in our patient. So this much variation is acceptable to us. Okay. But whenever the word bioequivalence come, don't forget about a drug phenytoin. So the exception to this rule is phenytoin. And with phenytoin, we never change the brand. With phenytoin, we never change the brand. Let's understand this concept. With phenytoin, the concept of bioequivalence does not hold true. Let's say the first brand of phenytoin is dilantin, which contains 100 milligram of phenytoin. And let's say this is the bioavailability. Now you went to the chemist said, sir, I don't have dilantin. I have another brand known as eptoin, which also contains 100 milligram of phenytoin, but made by different manufacturer. Now the problem with eptoin or dilantin interchanging is If phenytoin is little bit more absorbed, even this 25% variation is harmful. Little bit more absorption of phenytoin can lead to toxicity. Let's say it is 105% more absorbed, toxicity. If it is little bit less absorbed, let's say 95% absorbed, it leads to rebound seizures and the patient can die. So can we say with phenytoin, even 80 to 125% variation is not acceptable? Because of this reason, all brands of phenytoin are equal to each other? No, they are bio inequivalent. So with phenytoin, this concept of 25% variation does not hold true, or in simple layman terms, never change the brands of phenytoin in your patient. Never change the brands of phenytoin in patient, because this much variation is harmful for your patient. And this finishes your absorption part. Best wishes. Thank you.